Dr. Roseman, we're at the top of the hour.
Okay. So I'm Tyler Roseman, and today is our, for the COVID lecture series, we're going to talk about trauma to the lower genitourinary tract and try to go over the guidelines statements as best we can. I would, before we get started, like to thank the entire UCSF team, including Lindsay Hampson and Michelle Lifto, and all the other faculty and participants who have helped make this such a great lecture series so far, and I'm sure it's going to continue in the future. So about me, I'm from NASCAR country, and I went to school at the greatest basketball school in the country. And I don't have any disclosures. I'm an assistant professor at Virginia Commonwealth University, and we have a level 1 trauma center here. So before we get started, I'd like to find out a little bit about who's here today and so what your level of training is. So we'll give people about 20 seconds total to get their answers in. It's always interesting to see who is participating in these lectures. Good. We've got a good mix of years of residence, some fellows, some attendings, and even some medical students. So that's great. Good job, guys. Way to get started early. And then before this, I want to know how comfortable you feel managing in genitourinary trauma. Some of us are practicing at level 1 trauma centers, some are community hospitals. And so the amount of trauma that we get varies from location to location, and the types of trauma we get varies from location to location. So a lot of you are somewhat comfortable. About half of you are fairly either somewhat or very comfortable. So that's good. Hopefully after the end of this lecture, you'll feel a little bit more comfortable, at least with the knowledge base. I know some of that comfort comes with actual dealing with it. And then finally, how familiar are you with the AUA trauma guidelines? The guidelines came out in 2017 and have really been a way forward for us. A lot of our trauma literature comes from general surgery, and the urology trauma literature is fairly sparse in terms of high quality studies. Most of them are observational studies. So I think we could certainly do a better job in getting more. Okay, so kind of about the same in terms of how you feel about managing trauma. So some of this slide deck, or some of these slides come from the AUA core curriculum. I tried to condense a lot of that material down into into smaller chunks because there's a lot to get through. And so I'd like to thank the authors of the AUA core curriculum as well as the editor of the PowerPoint. So today we're going to review the epidemiology and etiology of lower GU trauma. And for this, we're going to include the bladder, urethra, and genitalia. I really had hoped to do the lower ureters as well, but I really just got to be too much to put into one segment. So hopefully the lower ureters you guys can figure out on your own, or someone else can teach you. We're going to evaluate the management of lower GU trauma, which really we break down into blunt, penetrating, and iatrogenic trauma, and then review the AUA guidelines. So in general, trauma is a top leading cause of death for people between the ages of 1 and 44 years old, and continue to be one of the top 5 causes of death overall. About 214,000 people die every year from trauma, which costs us about $671 billion by the 2013 estimates by the CDC. And for every person that dies, 13 are hospitalized, 129 are treated in an ER. And there are almost 3 million older people who are treated in the emergency room for fall injuries every year. A lot of sports-related trauma, and then a lot of motor vehicle accidents as well. So about 10% of all trauma is involved in injury to a genitourinary organ. Genitourinary organs are less commonly isolated injuries. Kidney is obviously the most common, but followed closely by bladder. Most of these injuries on their own are rarely life-threatening, but they can result in long-term morbidity and permanent disability, especially in the lower genitourinary tract. There's few of them need immediate intervention. Certain types of renal fractures certainly do. Testicular fractures can need some immediate attention, although this can be delayed. And then there's urinary drainage for pelvic fracture urethral injuries. So trauma, we try to break it down into lots of different categories. We talk about upper versus lower genitourinary trauma, blunt versus penetrating trauma, civilian and military trauma, and then iatrogenic trauma is another category that we often kind of gloss over when we talk about this. And then adults versus pediatric, and then there's another group called the geriatric trauma. And so we're going to talk about some of these special situations at the end. I am not going to discuss pediatric trauma as we're not necessarily in the guidelines, and I'm not a pediatric urologist, despite the hospital thinking I am sometimes. So when the AUA Guidelines Committee looked at the literature, they gave recommendations based on the evidence grades, and the evidence grades were based A through C, which A is well-constructed randomized controlled trials or exceptional observational studies, all the way to C, which are inconsistent observational studies with small sample sizes. And those are the majority of what the guidelines are made up of. They linked different nomenclatures to the evidence, including standards, recommendations, options, and then they also have things like expert opinion. So we're going to start off with the scenario here. This is Zach. Zach's a 28-year-old male with no significant past medical history. Motorcycle crash, and suffered a motorcycle crash. He was not able to void, and he had a positive FAST exam. There's no blood at his meatus, but this is his pelvic x-ray. So after you ensure that he is stable, what is the next step from the GU standpoint? Are you going to take him and explore him? Are you going to perform a cystoscopy, send him to IR? What's your plan? Okay, what's happening? All right, can everybody see my screen now? Since I lost everybody for a second. Awesome. All right, so how's the poll? So fluoroscopic cystogram, that's right. That's really the next best step in this patient. He has a pelvic fracture. He has bloody urine, and that indicates that he likely has bladder rupture. And so fluoroscopic cystogram or a CT cystogram would be completely reasonable. So the guideline statements, the evidence grade B, the clinicians must perform retrograde cystography with either plain film or CT in stable patients with gross hematuria and pelvic fractures. And 14B, clinicians should perform retrograde cystography in stable patients with gross hematuria and a mechanism concerning for a bladder injury, or in those with pelvic ring fractures and clinical indicators of a bladder rupture. So these are helpful in guiding us to who we should get cystograms on. So Zach becomes unstable. He's taken emergently to the operating room. Unfortunately, urology was not consulted until the pelvic packing was being performed because they were unable to place a catheter. So we placed an open suprapubic tube, and he was packed and taken to the SICU with a planned take back in the next day or two. While he's stabilizing, we did get a cystogram. Here you can see he's 3 different images of the same cystogram, and there's extravasation of contrast kind of in the anterior space, and you can see a wisp of contrast coming from right near where the bulb of the catheter is. This represents likely a bladder neck injury. So what about bladder trauma in general? About 10% of all GU trauma involves the bladder, which is second only to the kidney. And it can be classified as intraperitoneal, extraperitoneal, or combined. As we said, gross hematuria is the most common sign. And if you have a combination of pelvic fracture and hematuria, that will be present in about 16 to 27% of bladder injuries. In penetrating trauma, you may not see gross hematuria. Blunt injuries make up the majority of bladder injuries and often are associated with pelvic fractures. These are often from things like motor vehicle collisions, falls, industrial accidents. Penetrating injuries are rare because the bladder is protected by the bony pelvis, and gunshot wound is really the most common injury. Now, we should talk a little bit about iatrogenic injuries. They're generally associated with pelvic surgery, things like hysterectomy, C-sections, colorectal surgeries, that kind of stuff. And they can be full thickness or partial thickness. And if they're recognized at the time, they're relatively easy to fix. The AAST, or American Association, has a grading scale where they grade GU injuries from 1 to 5. And so they have one for bladder injuries as well, which really we don't utilize all that often. Grades 1 and 2 are really pretty minor injuries and oftentimes are treated with just catheter placement. 3, 4, and 5 can some more often require a surgical intervention. So the bladder sits in an extraperitoneal position in the pelvis and is bounded by the space of retzius and then the rectum or the uterus or vagina. Its vascular supply comes with superior and inferior vesical arteries, and it has various innervation patterns. In the evaluation of the trauma patient, history is oftentimes not the best, but it is important to find at least the mechanism of injury to see whether it's blunt or penetrating. And then, again, we should perform a retrograde cystogram with plain film or CT cystography. It's very important that it's a pressure cystogram with 300 to 400 cc's of contrast for adequate distension. Passive filling from just a bladder filling up with contrast from the IV contrast is not acceptable. Extraperitoneal bladder injuries, as you can see here, are contained inside the extraperitoneal space, and oftentimes are anterior lateral injuries. They can be managed conservatively for the most part. There are some exceptions such as concurrent vaginal or rectal injuries, bladder neck injuries, inadequate drainage or ongoing hematuria, or if there's foreign bodies within the bladder. You might want to consider putting them on antimuscarinics or antibiotics. Intraperitoneal injuries seen here on this fluorocystogram and here on this CT cystogram, you can see the contrast extravasating into the intraperitoneal space surrounding the loops of bowel. So this is our patient, his CT cystogram. Again, this looks like an extraperitoneal injury. That you don't see anything going into the intraperitoneal space up here or back here, but you do see it extravasating from an area that I would say is the bladder neck. So for For this, surgeons must perform surgical repair of intraperitoneal bladder rupture in the setting of blunt or penetrating external trauma. So all intraperitoneal injuries should be fixed. There are some that that in certain circumstances, such as in unstable patients that are small, can occasionally be observed, and there are case reports of in some series of observation of small intraperitoneal injuries, but this should not be the standard. Clinicians should perform catheter drainage as treatment for patients with uncomplicated extraperitoneal bladder injuries. And this is again a recommendation, evidence grade C, and there are some recent papers showing that maybe we should be repairing more of our extraperitoneal bladder injuries, but the key term here is uncomplicated. And then surgeons should perform repair with complicated extraperitoneal bladder injuries. So those are larger injuries and injuries that are associated with vaginal lacerations, rectal tears, as well as bladder neck injuries. And they also recommend with grade B evidence that urethral catheter alone without a suprapubic cystostomy is adequate for after repair of the bladder injury. So we took him back to the OR. We did an X-lap and a washout. We found a bladder neck injury as well as a separate extraperitoneal bladder injury. Repaired both of these and left everything since he already had a suprapubic tube to gravity drainage. And about 21 days later, here's his cystogram. So what are some tips for this type of operative exploration? One, you want to prep and drape the patient with the urethra accessible. So if the trauma team is taking him to the OR without you guys being there, then they're probably going to make sure that the penis or vagina are completely hidden from view. It's important because cystoscopy can be quite helpful to identify injuries in the urethra, as well as injuries in the bladder and foreign bodies within the bladder. If possible, it's best if you can get them to put them on a table that'll allow for fluoroscopy. Most of the standard tables that they utilize have a nice big post right in the middle, right where you would be doing fluoroscopy, because retrograde pyelograms might be necessary. You can consider a retrograde urethrogram on patients with anterior pelvic ring injuries with like a pubic diastasis or pubic rami fractures. And in unstable patients, you really don't want to open up the space of retzius, as this can cause massive bleeding from pelvic venous injuries. So on the stable patient, you'd probably start with something like a lower midline incision. However, if it's in a trauma situation, oftentimes they're going to have their belly all the way open. You just have to probably extend it down towards the pubic bone. And you want to open intraperitoneal injuries wide enough to explore for extraperitoneal injuries, close the multiple layers, put tissue flaps, leave a drain, all the normal stuff that we do for repairing the urinary tract in general. You want to use a large bore catheter and then a follow-up cystogram. So what happens after after bladder trauma? So the most common complication is persistent urinary extravasation, and that oftentimes requires taking back to the operating room. If they're not stable, or if they're doing okay with just bladder drainage, then you can try to weigh them out. If they do continue to extravasate urine, that can cause fistulization to the bowel, the vagina, the skin, all kinds of places that are not great. And then they can also suffer from pelvic nerve injuries. So I think we've covered bladder trauma pretty well here, and we're going to move on to urethral trauma. So this is our next victim, if you will. This is Slater. He's a 20-year-old male, was brought by ambulance to the emergency department after he got shot in the bilateral thighs. He has no intra-abdominal or vascular injuries, is stable, but he's got ecchymosis and swelling of scrotum and perineum. He's unable to void, and he has blood at the meatus. So in this instance, we can just look at the guidelines and say, what do we need to do? So clinicians should perform retrograde urethroplasty in patients with blood at the urethral meatus after pelvic trauma. And clinicians must perform an evaluation for concomitant urethral injury in patients with a penile fracture or penetrating trauma who present with blood at the urethral meatus, gross hematuria, or inability to void. So he had blood at the meatus and inability to void. He's kind of got the trifecta. So in your institution, in the trauma setting, how are the majority of retrograde urethograms performed? I know it varies from place to place, and especially in trauma, the quality of a retrograde uretherogram can be dubious at best. Some of that may be due to the patient positioning, as it might be difficult to put them in an oblique position. And some of it may be due to just lack of knowledge. Yeah, single shot flat plate by urology. That's what happens a lot. It's very rare that we can get radiology to do a fluoroscopic study, and sometimes they even ask us to come do it for them. That's really cool. Thank you. So he got a retrograde uretherogram, and as you can see here, he's in a reasonable position. He's probably about more closer to 30 degrees than 45 degrees, and you can see contrast filling out the pendulous urethra going into the bulbar urethra where it starts to extravasate. You can see that the bladder is already full of contrast from his previous CT scan, and then that yeah, you have some venous backflow going on here. You can't really see whether there's any contrast going into the past the sphincter. The sphincter looks nice and closed here, and it looks like with a lot of pressure, it just goes into the venous system. So what's the best management for this stable patient with a gunshot wound to the urethra? So immediate suprapubic tube placement. Okay, that's certainly an option. Primary urethral realignment, definitely an option. Observation, you guys avoided, which is good. And then primary urethroplasty. For some reason, you guys didn't pick that, despite the AUA guidelines saying that primary urethroplasty probably is the right thing. First, let's talk about retrograde urethroplasty. Retrograde urethroplasty is the best initial study for urethral trauma. You really want them in a 45-degree oblique position with the penis on stretch. Here you can see from this paper from Radiographics in 2004, the difference between kind of this flat plate urethrogram with the patient in the supine position versus what you can actually see in a oblique position. You can see kind of the entire length of the posterior urethra, whereas here everything looks like it's coiled on itself. You want the penis on stretch, and there's different ways to do that. I like to use either a Raytec or a 4x4 as kind of a little a tourniquet around the head of the penis to pull it out, so I can keep my hands out of the X-ray. But other people will use different devices to help with this. If you use a catheter, you usually use a 12 French with a few cc's in the balloon right at the meatus, and you don't want to use any lube, otherwise the balloon will slip right back out. We typically inject 20 to 30 milliliters of non-diluted contrast just to get a better picture. So here we have it. Surgeons should perform prompt surgical repair in patients with uncomplicated penetrating trauma of the anterior urethra. So this includes stab wounds and gunshot wounds, as long as they are low caliber or low velocity gunshot wounds, which encompasses most of the handguns that we see. So we took him to the operating room, and as you can see, we performed basically a similar exposure as a urethroplasty. We dissected the urethra out, and we can see he's got damage to his corporal bodies here, and he's got damage to his urethra here. The ventral plate appears to be relatively intact. So we did some nice debridement of the edges of this urethra, and then repaired it in a non-transecting fashion. At the same time, we repaired the corporal bodies. The left corporal body we had to use a off-the-shelf graft to repair because we just couldn't get it together. There was too much tissue loss. And 2 weeks later, here's his post-op VCUG. He had a kind of a nervous bladder, but he was able to void in the bathroom afterwards. So urethral trauma is uncommon. It's only 4% of all traumas, and blunt force trauma makes up the majority of this. We kind of divide the trauma up between whether it's anterior or posterior urethra, or blunt or penetrating trauma, and then we also include iatrogenic trauma, which is usually endoscopic. The urethra is broken up into 5 segments, according to some, 6 according to others. Those who include the bladder neck as part of the urethra. So, but the posterior urethra and the anterior urethra are divided by the genitourinary diaphragm, with the bladder neck, prostatic urethra, and membranous urethra being the posterior, and then bulbar, penile, and fossa navicularis being the anterior. The urethral blood supply comes mainly from the internal pudendal down to the common penile, and the urethra really has 2 blood supplies: the bulbar arteries, and then the dorsal penile artery that arborize in the glans penis, which is very important for urethral reconstruction later on. Blunt trauma encompasses about 85% of urethral injuries, and the bulbar urethra is the most often affected. Posterior urethra really is associated with pelvic fracture, and about 3 to 6% of both men and women with pelvic fracture will have a pelvic fracture urethral injury. It can be associated with Malgane or vertical shear forces, as well as pubic symphysis, diastasis, and anterior pubic rami fractures. It can be also penetrating injuries are oftentimes gunshot wounds and or stab wounds in the anterior urethra, but there can also be things like bites. The AAST has a urethral trauma scale as well, and again, we don't really utilize this all that much, although if you look at the general surgery trauma literature, they use it fairly frequently. But the the grade really does kind of correspond with management. So about 35% are grades 1 through 3, and about 65% are grades 4 and 5. And these include complete disruptions. Complete disruptions in general are typically managed conservatively initially with delayed repairs when we're talking about pelvic fracture urethral injuries. The diagnostic triad of blood at the meatus, suprapubic fullness, and urinary retention is what we look for. You may see perineal hematoma, and then a blood that's confined by Buck's fascia. Retrograde urethrogram is the best initial test in men. However, women, it's fairly impossible to do a really good retrograde urethrogram. So flexible cystoscopy or a rigid cystoscopy with a female cystoscope is the most important. I'm not going to belabor the pelvic fracture urethral injuries because Dr. Hampson did a very great lecture, and this is the link to the lecture just a few short weeks ago. So I encourage you to look at that for a really in-depth picture of pelvic fracture urethral injuries. So when we work up the urethral trauma, retrograde urethrogram is important, as we've discussed, and then cystoscopy. Pelvic x-ray may help give you some idea whether there's a pubic symphysis diastasis or an inferior pubic rami fracture. Cystogram to evaluate for concomitant bladder injuries, and then a rectal exam if there's penetrating injury to the posterior urethra. Management in the anterior urethra, if it's a blunt injury, typically it's urinary diversion with a Foley or SP tube. Penetrating injury, immediate operative intervention. We typically like to do this like a urethroplasty with absorbable sutures, primary spatulated repair, especially in the bulbar urethra. Posterior injuries are more often managed initially with just urinary diversion, which can be a suprapubic tube. You can do endoscopic realignment within the first 3 to 10 days after the injury, but you don't really want to put a prolonged effort into it, so probably less than 20-25 minutes. Otherwise, you're really going to put a lot of fluid into there into their pelvic space. Immediate repair is not indicated in posterior urethral injuries unless it involves the bladder neck. So, what do the guidelines say? Clinicians should establish prompt urinary drainage in patients with pelvic fracture-associated urethral injuries. Surgeons may place suprapubic tubes in patients undergoing open reduction and internal fixation for pelvic fracture. This is an expert opinion. However, you will often see the trauma or the orthopedic surgeons balk at us putting a suprapubic tube if they're performing an ORIF, saying that they think that it will get infected. This is not true. We don't have any evidence that there's any increase in infection from a suprapubic tube to an ORIF, despite what they say. And then clinicians may perform primary realignment in hemodynamically stable patients with pelvic fracture-associated urethral injury, but should not perform prolonged attempts at endoscopic realignment. And clinicians should establish prompt urinary drainage in patients with straddle injury to the anterior urethra. Straddle injuries often are from either falls or direct trauma to the perineum that compresses the bulbar urethra up against the pubic bone. So what about women? Women also suffer urethral injuries, and here's a case of a 9-year-old female who fell off the playground equipment while climbing, and really this is an avulsion. Her urethra, you can see down here and here with the catheter in place, is really avulsed off of her anterior vaginal wall, along with the rest of the anterior vaginal wall. We performed a cystoscopy to evaluate for any urethral injury, and there was no internal tears. So we reattached it to the pubic symphysis and repaired the vaginal lacerations primarily. She did very well afterwards and did not have any incontinence. So in women, cystoscopy is the best tool for diagnosis of urethral injuries. And then you should repair it at the time of presentation unless they're unstable to decrease future incontinence or fistula. Distal injuries you can sometimes observe. So what kind of long-term complications do we have? Things like stricture stenosis, diverticuli, infected urinomas, fistulas, erectile dysfunction, which can be arteriogenic or neurogenic, and can recover after 1 to 2 years. And then incontinence, especially if there's a bladder neck or pelvic nerve injury. Incontinence is not common from a sphincteric injury because the bladder neck is typically intact. So the AUA trauma guidelines do recommend monitoring patients for complications for at least 1 year after urethral injury. So next we have genital trauma. And genital trauma can be, again, blunt or penetrating, and blunt trauma are things like contusions, lacerations, avulsions, or burns are the most common, and account for about 28 to 68% of patients with GU trauma will have other injuries to the genitalia. They're not usually life-threatening, but they can have long-term complications such as impaired fertility, sexual dysfunction, endocrine changes, and psychological damage. Here we have Samuel. Samuel's a 25-year-old male who was in a motorcycle accident. He ran into the back of a car after he flew over the handlebars and felt his groin hit on the gas tank. He was cleared by trauma except for an enlarged right hemiscrotum, which complained of excruciating pain and had been swelling. So here we have a kind of scrotal and testicular trauma, which is fairly rare because the scrotum is typically mobile, protected by the tunica albuginea, and the testicles will retract due to the cremasteric muscles. Typically, so about half to 85% are blunt injuries, and usually due to sports. They can also be involved with scrotal injuries as well. And then you'll see them have swelling, ecchymosis, hematoma, and potentially skin avulsions. Penile or scrotal Doppler ultrasound can be helpful in evaluating the echotexture and contour as well as the blood flow. And it really should be an adjunct to your examination. So our guy, Samuel, he had a large hematoma in the right hemiscrotum. His scrotal skin was tight, edematous. You couldn't really palpate the right testicle, so we got an ultrasound. And here we have the left over here, which has a nice normal appearing border and normal echo texture. And here we have the right. You can't really tell if the border is completely all the way around, and certainly there's a large hematoma that's inside the testicle as well. The testicle has a significant blood supply that is separate from most of the other perineum, typically coming from the testicular artery. It also has secondary blood supplies from the basal artery, as well as the cremasterics. So in this instance, surgeons should perform scrotal exploration and debridement with tunical closure when possible, or orchiectomy in patients with suspected testicular rupture. So we think our guy probably has a testicular rupture, so I think we're planning on an exploration. And then for the scrotum, surgeons should perform exploration and limited debridement of non-viable tissues in patients with extensive genital skin loss or injury from infection, shearing injuries, or burns. So how do we manage testicular trauma? When it's a blunt trauma and there's no evidence of testicular rupture, observation is completely reasonable with rest, ice, compression, NSAIDs. Surgical management for fractures or for more complex hematomas is completely reasonable. For penetrating trauma, certainly if it penetrates the dartos of the scrotum, then we would say exploration would be necessary. So we explored him, opened everything up, and this is what we see. He's got tunica vaginalis just kind of controlling everything and holding it in. And then as we open that up, we can see there's been some loss of tunica albuginea and some non-viable testicular tissue. So debridement and then primary closure is completely reasonable. However, sometimes there can be larger segments of loss of tunica albuginea. And for patients who have that, you may not, if they have a viable testicular tissue, you may not want to just perform an orchiectomy. So a group published this in the Journal of Pediatric Urology, and it was a series of 4 pediatric patients with large tunical defects. And they performed a tunica vaginalis pedicle flap for repair of ruptured testis. And all 4 patients did well with relatively normal size of their testicles, which otherwise you would have to debride a large segment of these tubules here, or perform an orchiectomy. So keep that in your armamentarium. So what about scrotal trauma? Scrotal trauma, again, can be blunt, can be penetrating. Typically, it's managed with exploration, washout, and limited debridement with primary closure. The scrotum has a great blood supply, so primary closure typically works pretty well. But for burns, you may have to limit your debridement because it can be an insidious onset later on. So, and you may want to consider urinary diversion if the burn is full thickness or involves the urethra. So, moving on to the penis. Penile injuries are uncommon due to the flaccid mobile nature of the penis, and the management is typically operative to improve sexual function and cosmetic outcomes. Categories can include blunt and penetrating, but we also include things like amputation of the penis, so the John Bobbitt injury, and then the strangulation of the penis, so things like hair tourniquet or penile constriction devices. Blunt injuries to the penis often result in penile fracture, which is a corporal cavernosal tear, and it's the most common type of blunt injury to the penis. It's usually secondary to erect penis hitting the pelvic bone or perineum during intercourse. You should look for several things: POP, rapid detumescence, and an eggplant deformity or hematoma, and then ecchymosis of the shaft and scrotum. You can consider an ultrasound if they have severe pain or equivocal exam to evaluate the integrity of the corpora cavernosa, and you could also consider an MRI. However, it's expensive, and not every location has the capability of doing it. These are typically managed surgically, which includes exposing the injured corpora and a primary repair. So what do the guidelines say? You should suspect penile fracture when a patient presents with penile ecchymosis, swelling, cracking, or snapping sound during intercourse or manipulation and immediate detumescence. You should perform surgical exploration and repair in patients with acute signs and symptoms of penile fracture. And you should perform ultrasound, or may perform ultrasound in patients with equivocal signs and symptoms of a fracture. And then you should evaluate them for concomitant urethral injury in patients who have blood at the meatus or gross hematuria or inability to void. And this can be with cystoscopy or retrograde uretherogram. So here's an example of a penile ultrasound. And this is a patient we actually treated on Christmas Day who came in. And you can see here that the tunica albuginea is nice, and even up until this point, and you can see an injury right there. Here it is in kind of a longer longitudinal format, and then here you are in more transverse images. And so it's really highly dependent on your operator to see if they can find these things, and it's helpful if you are at the bedside at the time that they are performing the ultrasound. Patients will often come with a fracture here, and it's usually lateral and ventrally and towards the base of the penis, though I've seen them kind of everywhere. And then if it does involve the urethra, then you should repair the urethra at the same time. Most of these injuries can be dealt with from a ventral midline incision. However, if you're not sure where the fracture is, there's no shame in degloving the penis entirely and finding the area of injury. So penile injuries can also be penetrating, oftentimes gunshot wounds or stab wounds. Again, it often involves surrounding structures like the thigh scrotum or urethra, and you should consider the urethra if there's blood at the meatus or difficulty voiding. Again, you're going to explore this, debride it, wash it out. Oftentimes, you can't tell just from the external exam whether the wound has penetrated into the tunica albuginea or not, and so you should explore it to make sure. And then amputation, we'll just say a few words about that. It's usually self-inflicted with treating underlying mental health issues, and you can usually reattach these within 24 hours. So this is Dennis. Dennis is a 35-year-old man who comes in 26 hours after placing a metal penile constriction band around the base of his penis and scrotum. He's having worsening pain and swelling, and it's made it impossible for him to remove it. He's tried butter, lotion, oils, but nothing has helped. He has been able to void, fortunately. And here he is. This is his brand new penile constriction device that he placed behind the scrotum and penis, and is not able to get it off. Penile strangulation is uncommon, mostly case reports or case series, and often by rubber or plastic or metal objects. The removal varies based on the type of object, and sequelae are things that you would expect: fistula, stricture, penile skin loss, amputation, and even a reported death. For metal constriction bands, it's very important to cut them at both ends, and finding the right tool can be fairly difficult, but a metal cutting burr saw is typically pretty helpful. So let's put it all together. This is Kelly. She's sent from an outside hospital. A 19-year-old female, experienced pelvic trauma when jumping in the river, otherwise healthy, fairly stable, and has a 1.6 centimeter diameter wooden branch hanging 6 centimeters out of the vagina. No perineal or labial bruising, normal rectal exam. This is her fast exam. And as you can see, here's her bladder with what looks like a foreign body sticking up into the bladder. So what else would you do to evaluate her injuries? And if you can, choose all that apply. All right, so cystoscopy, yeah, CT urogram seems reasonable. Cystogram seems reasonable. Retrograde urethrogram, going to be fairly difficult. This is a female. Retrograde urethograms are difficult in their own right, but she also has a branch sticking out of her vagina and probably is fairly uncomfortable. And then nothing, I have all the information I need. I guess you guys are cavalier and just know what all you need to do. So we got a CT cystogram, and this is her pre-contrast imaging. As you can see, there's a nice big foreign body sticking, going through the vagina and sticking into the bladder. With contrast, you can see it's outlining the stick. So now what do we want to do? How would you approach this impalement? Would you just remove the stick and put a catheter in and send her home? Or would you try to fix it? And if so, how? So I think almost all of these could be correct, except for the conservative management with the Foley catheter. I don't think you're really going to get anywhere with that. Certainly, you want to repair it. You can do it open or transvaginal. I think there might be some people that could do it robotically or laparoscopically. I certainly am not one of those people, but we chose on her a transvaginal approach. So we set her up. First, we performed a cystoscopy because we wanted to check out her urethral orifices, and we found a little fringe sitting in her bladder. I guess my video is not going to play. That's all right. We removed the stick after we saw it sticking into the bladder, right around just superior to the trigone, and maybe about 1 to 2 centimeters from the urethral orifices. We removed the foreign body. We did a transvaginal repair in about 3 layers after copious irrigation and broad spectrum IV antibiotic coverage. We left the catheter in for about 14 days. And she only stayed in the hospital 2 nights. Performed a cystogram, which was completely normal. So I just want to say a couple of words about special populations. So geriatric trauma, there's a study out of the trauma, or out of the Journal of American College of Surgery, that showed that geriatric trauma can be different from the rest of the population, and significantly so that really the mechanism of injury is quite different, for mostly motor vehicle accidents and falls, and less firearms cuts and motorcycle injuries. The bladder is injured more often in patients over 65 than under 65, and the penis is injured less often in patients over 65 than less than 65, as well as the testicles and scrotum. And then you can see here that there is a significant increase in blunt trauma compared to penetrating trauma. And then military trauma is also another area of study that has been growing in literature in recent years. So combat GU trauma has really been a small proportion of 20th century conflicts. About 0.5% of all injuries in World War II were combat related, were GU trauma related. About 8% in Vietnam. A group looked at the Department of Defense Trauma Registry for Operation Enduring Freedom and Operation Iraqi Freedom, found there was about a 5% rate of GU trauma for all the people in the registry. 890 patients with GU trauma injuries, and really over half of those suffered lower GU tract trauma, which is different from what you would expect in the civilian population. And only about 4% of these are isolated GU injuries. Scrotal and testicular and penile injuries were the most common. And you can see here that the penile and testicular injuries really did have a pretty significant, had less grade 5 injuries in the penile, but really a lot of grade 5 injuries in the testicular injuries. And And you can see that the number of IED injuries increased significantly after 2010. So, and a lot of these had significant associated injuries as well. So this is really a separate population defined by a separate type of injury, the IED, as opposed to in the past what was more gunshot wounds. So I think we have some time for questions, and I'll take anything that we have. And don't forget to fill out your survey after the lecture.
All right. Thank you, Dr. Roseman, for that great talk. So I was fielding some of these questions. The first question was asking, do you ever consider attempting placement of a catheter in the setting of like a motor vehicle accident when a rug or any sort of diagnostic imaging isn't readily available? Have you ever attempted it all?
Yeah, I think a single gentle attempt at placement of a catheter is completely reasonable. There has been the thought that you will turn a partial urethral injury into a complete urethral injury, but I don't really think that that has really borne out in any of the literature. So I think a single attempt to place a catheter when you don't have the ability to do a retrograde urethrogram or scope in anything is completely fine. I don't think you're going to harm anything, and you'll know pretty quickly if you get urine back or not.
Okay, then another question is, when are you suspicious of bladder neck injuries?
That's a good question. I think you really have to be suspicious for the more severe pelvic traumas, and then really you're basing it off of, the more severe like pelvic ring injuries, and really you've got to base it on the cystogram, and a lot of us will look at a cystogram and just say whether it's intraperitoneal or extraperitoneal or nothing. And you really have to look at the subtle findings, so where the contrast is extravasating from. So if you see a lot of contrast kind of right at the level of the bladder neck, then that's going to be more consistent with a bladder neck injury. So you want to look at where the contrast extravasates from and maybe where it extravasates to.
If you have urethral injury and that requires cystoscopic placement of a Foley catheter, how long do you generally leave a catheter in place for?
So if you're talking about like an endoscopic injury, then I would leave it 3 to 5 days. If you're talking about like a actual tear in the urethra, then I would probably leave it at least 2 weeks and maybe a little bit longer. If for urethral injuries, I'm not going to leave a large bore catheter. Really, 16 French or 18 French would be fine. I would not go any larger than an 18 French because then you increase your risk of meatal stenosis.
In the setting of a gunshot wound, do you have any consideration for the velocity or the energy that's delivered in terms of how you plan or approach your repair?
Yeah, so if you look at recommendations that for high velocity injuries, they recommend a delayed repair. Now, how do we know what the velocity of the bullet was when it hit the victim? We don't really. We can kind of go off of what they tell us. Most of the handguns that we see are going to be of the lower velocity variety. High velocity injuries are typically more things like hunting rifles or assault rifles, and that's not really going to be the majority of the gunshot wounds that we see typically.
And as far as penile fractures, do you typically advocate repairing them immediately, or could you repair them the next day?
That's a good question. I think the literature is mixed on this, and if there's no harm in waiting to the next day in almost any circumstance. Most of the literature has looked at treating it in under 8 hours versus over 24 hours. So there's a 16-hour window. We don't know what happens between 8 hours and 24 hours. And it may be better in certain circumstances for your ideal repair to wait for the person who's most qualified to repair it with the team that's best able to do it. Now, you don't want to have somebody sitting in the hospital day after day after day, especially if they're in significant pain or if they can't urinate. Certainly, if they have a urethral injury, that's a reason that you might want to repair it in a more immediate setting.
In the case of a suspected urethral injury in someone who's had a motor vehicle accident or collision, when would you, or how do you go about deciding what kind of catheter you want to place, whether it be a urethral catheter versus suprapubic catheter or any other options?
So if they've got a let's just say they have a complete urethral injury, so like a pelvic fracture urethral distraction defect, certainly getting drainage sooner rather than later is the key, because their bladder is probably already full and it's getting fuller because they're getting lots of fluids in contrast. So you may not be able to take them for a cystoscopic realignment right away. So suprapubic tube is what I would typically aim towards. And then potentially a urethral realignment if they're being taken to the operating room for something else, which oftentimes they are. So you can coordinate that. But personally, I kind of aim for the suprapubic tube just to get relief. But, you know, there's a lot of debate about that.
Do you have any pearls as to what to do when there's a urethral injury and there's a lot of tissue loss during or after debridement?
So typically, if you have a significant amount of tissue loss, and you're talking about in the immediate setting, if you have an anterior urethral injury and there's significant tissue loss, then you are not going to be able to get the urethra back together very easily, unless it's in the bulbar urethra where you can mobilize a little bit better. So at that point, you probably are thinking about kind of urinary diversion, debridement, packing, and then when you ultimately repair them, they're going to likely need grafts.
Okay. Concerning penetrating urethral trauma, would it be more beneficial for a patient to have a suprapubic tube placed and wait 1 to 3 days for urethroplasty for a general urologist on call if there's a reconstructive specialist in the practice?
I think that's completely reasonable. Yeah. I think a lot of the stuff that we deal with in trauma, you may not have the ability to wait, but for certain things like a urethral injury, waiting a day or 2 days is probably not going to cause any harm, especially if they're going to be taken care of by someone who has potentially more experience.
Okay. And what is your typical time frame for if you were to place a suprapubic catheter in terms of then going on to do a urethroplasty?
For a pelvic fracture? So probably about, I would wait at least 3 months. A lot of it depends on their other injuries and how they're healing, and then also their mobility. So if you have somebody who still can't really sit down effectively or bend effectively at 3 months, then performing a urethroplasty is going to be really difficult. So you have to wait for a lot of their other injuries to heal. But I think most people would agree 3 months is pretty reasonable. There are some groups that have advocating early urethroplasty, like at 6 weeks or so, but I think the majority of people would say 3 months.
Okay. Well, that seems to be all of the questions so far.
Awesome. Well, if there are any more questions, I'll be happy to take care of them and put some answers online.